So let me just briefly, this panel is going to look at this question of making the case for cancer treatment and UHC. Let me just introduce the various discussants here. So Esteban Burrone. Oh, sorry. That's the hazard of not actually being able to meet everybody beforehand. Head of Policy, Medicines Patent Pool. Thank you very much for joining us, Jayasree. Iyer, who is the Executive Director of Access to Medicine Foundation, and Dr. Indranil. There we go. I do apologize. Senior Vice President and Head, Global Value and Access, Novartis. Lisa Stevens, Director of the Program for Action for Cancer Therapy at the IAEA. And of course, known to everybody in this room, Dr. Mary Gospodarowicz, Medical Director, Princess Margaret Cancer Center, and former, of course, past President of UICC. So let's just jump straight into this. And I'm going to start, Esteban, if I can, with you. So you've worked, the MPP rather, has worked over the last 9 years to improve access to affordable and appropriate essential medicines, particularly in low and middle income countries. And you focus obviously on HIV, hepatitis C, and tuberculosis. And the mandate of MPP, as I understand it, has now recently been expanded to include NCDs. I wonder if you would just, including cancer, of course, can you explain how and why that's happened and why that came about?
Yes, sure. So if you step back a little bit, back to, say, 2010, when we were being established as an organization, as a organization that sort of came out of the World Health Organization, you would look at the WHO model list of essential medicines, which is usually referred to as the EML, and the vast majority of drugs that were on that list were old drugs, generally drugs that were off patent. And there are all sorts of challenges in making those available in lower middle income countries. But there was one major exception, and that was HIV. You had several new medicines for HIV, which were in many ways better than those that were widely being used or were being used to scale up HIV treatment in those countries. And the idea at the time was to see how can we make possible for these new medicines that have improved side effects, better efficacy, reach those who really need them in the developing world where the real burden of HIV, the massive burden of HIV was. And that's where we came about as an organization, to work collaboratively with the pharmaceutical industry to see under which conditions they would be willing to allow quality assured generics to come in early, several years before patent expiry, at affordable costs in a way that was completely compatible with their business model and yet made access possible in those countries. Now, fast forward a few years, and you start seeing the WHO Essential Medicines list increasingly at every revision that happens every 2 years has been adding new NCD medicine and new cancer medicines. Not many of them, those few cancer medicines that in the view of the WHO's expert committee really can make a significant difference in health outcomes in low and middle income countries. So in that context, when the WHO is seeing how can we ensure that essential medicines are available, affordable, and accessible, let's turn to those things that have worked in areas like HIV. And that's how we came in, and we've been asked by the WHO to consider expanding into these new areas.
So what are the lessons then you take from HIV, hepatitis C, so on, into the area of NCDs and cancer in particular? How do you translate? Because we're dealing with infectious diseases versus chronic disease, quite different set of problems.
Exactly. I mean, I think we have to be very careful not to simply think, because something has worked in one area, it's definitely going to work in another one. I think what we saw in HIV that is pretty much become a standard today is you have a new medicine coming to market in the high-income countries that can offer real benefits for the population. And within 3 to 4 years, you see massive scale-up taking place in low and middle income countries. So the lag, what used to be a lag of 8-10 years, where only a few people who could afford it could access those medicines, those improved medicines. And let's remember, new medicines doesn't necessarily mean greater cost to health systems. Often they can mean less cost to health systems, because often these are drugs that may have lower side effects and therefore require less monitoring. So the health system cost, actually introducing new medicine at times can actually mean lower health system costs. So it actually can lead to significant price reductions. Now, one thing I'd like to say is, people say, okay, you've been in HIV, that's different. What about cancer? Well, I'd like to remind people we actually have been working in cancer for the last 4 years. Hepatitis C and hepatitis B, so viral hepatitis, is one of the leading causes of cancer, of liver cancer today. And we've seen a similar kind of projection taking place. New medicines coming to market that could really make a difference. Initial costs being prohibitive in low and middle income countries. Today, you can get access in low and middle income countries covered by the licenses that we've jointly negotiated with the pharmaceutical industry. Today, you can get a treatment course, 12 weeks, for about $100 in over 100 countries.
That's even for drugs that would otherwise cost, as I understand it, $20,000 to $30,000 US if you were doing it in the UK, is that right?
Correct. And so, prices have come down over time in high-income countries, and there's been lots of efforts to make that possible, including with higher volumes of people being treated and more efforts. But the key point I'd like to say is, when that was starting, people were saying, in many countries, there's no point in screening for hepatitis C. Why would I go out and screen if I cannot really offer anything to treat people with? The alternative drugs were way too expensive, but also had significant side effects and very low efficacy. And so the moment you started having the possibility of treatment, that changes the equation. That starts to mean that you can consider putting in place hepatitis programs. You consider having a screening program, and that's starting slowly. And you still have many people who don't have access to treatment for hepatitis. But that has been possible partly because now you have the possibility of treatment, of quality assured and effective treatment. And that's the kind of dynamic we'd like to see in cancer more broadly.
So a couple of questions that raises to me. One is, how do you strike that arrangement with companies like Novartis to do something like that? And the second thing is, if you can strike that arrangement, at least temporarily, that's fine in the short term, but what about the long-term sustainability of financing something that otherwise is generally quite expensive? And I also, if I could come over to you,
sure.
And ask you
and
that.
I'm glad you bring the concept of sustainability, because that's part of the challenge of what we're facing today. A lot of the access initiatives that we're seeing today have been really effective at the local level in those specific pilot countries where they have been done. Donations, small-scale pilot programs can be really useful for those who can benefit from them, but they don't result in a sustainable health system. That's not the way we're going to try and address it. When we look at the dynamics, you see that there are a lot of products coming to market where the market, really, the commercial returns are going to come from certain countries. And what happens with the other countries? Often there's no strategy there, or that strategy may come about 10, 15 years later. We can shorten that time, and having Novartis here is actually a really good example, because the Novartis CEO is committed to make for every new product that gets launched, there should be an access strategy in place at the time of launch. Now, that is revolutionary, and I think that's great, and that's what the kind of initiatives start trying to think. Now, it's not every single medicine that Novartis or other pharmaceuticals coming to market that will be key and have a significant public health impact in low and middle income countries. Can we zoom in on those that can really make a difference and develop strategies that can include royalties going back to the pharmaceutical company? You can make these also commercially interesting, but also, and most importantly, from a public health perspective, very impactful. And that's what we'd like to see, bearing in mind that medicines in cancer, as all of you know much better than I do, is only one part of a much more complex system. So we shouldn't be thinking of the miracle medicine that will change the world. That's possibly true in hepatitis C. It's probably not true in other cancers. But yet, we cannot, just because that's not the case, we don't think there's so many other problems that we're not going to try and solve this one.
It's certainly true in HPV, as we've heard earlier, that if you put the system in place, I mean, both vaccination and other things, that's important. And of course, low and middle income countries have benefited, haven't they, from that low cost access to HPV vaccinations. Indranil, can I just ask you just to comment on that? I mean, clearly here is a process. You're engaging that process right at the very beginning, at the access point, at the discussion about when a new drug comes out, what are you going to do in terms of access? Tell us about how Novartis thinks of this.
So first of all, thank you for having the opportunity to be able to participate in this. Thank you, Esteban, for bringing up what we're trying to do as a company, as an industry, and as a public-private partnership in terms of addressing the needs for the populations across the world. Maybe a few quick comments before we dive into the details. As a company and as an industry, we are trying to change our approach to access. And like you said, historically, the way this has worked is any new cancer medicine, any new specialty medicine, historically, the focus has been on developed markets, but that is changing. And yes, you mentioned our CEO's commitment. We today, as we are trying to bring our new medicines to society, we take a look at global needs. We take a look at what are the different populations across the world that will benefit from the medicines we bring, and what would be the different strategies that we need to adopt to make sure these medicines meet the needs of the population in those respective countries. A couple of examples I'll give are, one is our tiered pricing approach, where we take a look at the 170 plus countries that we do business in, and making sure we price the medicine in line with the GDP or the GNI. In some cases, it might be a donation. In some cases, it might be co-shared funding. In some cases, it may be co-pay assistance. In some cases, it's just a regular business model. The needs are different, and we make sure we meet the needs accordingly. It's also, another example is our emerging market brands. Historically, emerging market brands, which are obviously in the least developed countries as well as low middle income countries, would be launched 1-2 years later. Our most recent breast cancer treatment, we have launched in India and some other emerging markets within 5 months of the first developed country launch. So a couple of examples there where we're really trying to change the paradigm and address access in a different way than we have done before.
So how much difference is this really making in terms of access that countries have to your cancer drugs?
So, it depends. It's in the eyes of the beholder. I'll give one statistic, and Jayasree is sitting right here. So access to medicines is something tracked by the ATM Foundation. We moved from number 3 to number 2, and our goal is to get to number 1. But numbers are what they are. In the end, how are you making a difference? In low middle income countries over the last 3 years, we have essentially doubled our impact in terms of the number of patients we're reaching. Overall, globally, we are reaching 1.1 million patients and counting. And like I said, our time to lag to launch, our current record is 5 months, and we are trying to get it to at parity between least developed countries, low middle income countries, and developed countries.
So I suppose one challenge of this approach would be that, in effect, by reducing the price of, giving access under a reduced price of drugs to countries means that possibly countries take up inappropriate treatments for cancer when they could be using that money to do other things. The prevention is one of those things. Radiotherapy might be another. That obviously is a criticism that's come across, I know, quite a few times. How do you address that?
So I think, again, often when we talk about challenges that face access, we quickly go to the medicines, but sometimes the challenge is much bigger, right?
Yeah.
So the infrastructure in many of these countries in terms of getting the medicines to the right patient at the right time just doesn't exist. Many of the new complicated cancer treatments that are coming to society have complicated companion diagnostics, and those diagnostic features may not be available either. So our focus is along kind of 3 lines. One is affordability. I mentioned already pricing the medicines in line with GNI, GDP, etc. Second piece is focus on the healthcare system and work with public partnerships in terms of improving the healthcare system and making sure, even if we make the medicines free, they actually can get to the right patient at the right time. And the third piece is focusing on some sort of treatment algorithm. Prevention first, early detection and diagnosis second, and then having the right drug for the right patient at the right time third.
Really, really interesting. Jayasree, I want to, I see you nodding and nodding at my questions, but then also nodding at Indranil's answers as well. So can I just ask you, you've done the Access to Medicine Index now for up to, I don't know how long it's been going on for the last 10 years, but you've evaluated 20 of the world's largest pharmaceutical companies. Novartis is moving up the ladder, which is kind of interesting. How has the industry done in terms of engaging with this question of access to medicines, do you think?
Yeah, so we've been doing an evaluation of the largest, 20 largest research-based companies for over a decade. I think it's about getting into about 13 years already. And we just published a report looking at a 10-year, has there been progress? Has the industry responded? And what's the pace of it? What's still left to be done? What you see in access to medicine, and maybe I'll focus the conversation on access to cancer care, is there's definitely been a more strategic focus coming from the pharmaceutical industry in access to cancer care. And part of that is because of the high-level attention that has gone into access to cancer care through forums like this. Part of that has also been the step that has been made by vehicles that have been successful in areas like HIV and hepatitis in saying that this is possible for cancer, vehicles like the Medicines Patent Pool. Part of this has also been due to the expansion, as priority setting always works, that essential medicines lists have also been increasing, the number of cancer products that are put on the table, and there's much more awareness. So we've seen the strategic focus of companies into sub-Saharan Africa increasing from about 8 a decade ago to the majority of the companies that we're looking at is about 16 companies who are very strategic focus in sub-Saharan Africa and expanding access. And all the companies that have oncology in their portfolio, which is 19 out of 20 of our companies, have included cancer into that strategic direction. So it's part of the model that they're envisioning for time. The problem comes in that when you do look at the activities that have been going on for the last decade, we scanned through about 121 initiatives of the pharmaceutical industry, ranging from donation programs, very often with the Max Foundation, like Novartis' GPUB, I think you'll be talking about it in a few minutes, to discounts offered in several different geographies, like some of the initiatives from Roche, for example, in China, to the Pakamisa project, that is quite a long-running project for AstraZeneca in Kenya. So we've looked through all kinds of initiatives, including philanthropic funding that is going into capacity strengthening, improving education, improving oncology. We said, let's look at everything in order to see this. And the bulk of the activity, when you think of the core role of the pharma industry in treatment, is still at the level of addressing a very small population that benefits from this. So when you think of the treatment-eligible patients that are out there, and you think of the initiatives that are in place, some of them are very good. They make very strong impact. Not many of them even reach the scale in the donation programs, don't reach the scale of the GPAP program even. So what we are missing is a sustainable approach for how can we make sure that we're able to bring new medicines and old medicines to scale, because 83% of the world's population live in over 100 countries that we're dealing with. So I think the vision, we have to look at the vision of the pharmaceutical industry all over again, right? If the vision of any pharmaceutical company executive is to make sure that every treatment-eligible patient will one day get access and one day will be on treatment that is being developed by your company, then the vision should match this corporate strategy. The corporate strategy should address scale. So we must be able to inbuild that scale. And that scale is now actually possible. I'm eating into this potentially my second question. The scale is possible because we do have mechanisms, and the expansion of the Medicines Patent Pool is looking at markets. It's looking at products that are in the essential medicines list, are potentially going to be added in the future to the essential medicines list. And I think that's important to expand that scale so that more people are able to reach access.
So just to be clear, there's a number of things that companies are doing, and it's not just in making access affordable, it's also in building capacity and a whole range of other things that, working with patient groups, I've certainly come across that quite often. It's not just giving direct access, is it? But what you're saying, it seems to me, is that actually that's where the real gap is, and that the fundamental need to scale that up and scale that quickly is what needs to happen, rather than just doing it for small populations within countries where it only addresses certain needs. So now we kind of, if that's the problem, what is the solution? How do we move to that? And I'd really like to hear, Indranil, your points. Before I come on to the other forms of treatment, what are the solutions?
So I think that every partnership has a piece of the puzzle. And if you put them all together, you might actually get closer to the solution. So it starts with access planning at the R&D level, right? So let's just follow the pharmaceutical value chain and when you think of the different solutions. if you ensure that there's access planning in every molecule that is being developed or co-developed in partnership, that means faster registration, that means broader registration in prioritizing countries that have a high burden of disease, where treatment is possible, at the same time ensuring that there are capacity building initiatives that ensure that future markets treatment is going to be possible. It's something that companies can look at. It means filling up dossiers, designing clinical trials differently. It means talking about affordable access, looking at the financing models available already when the product is in clinical stages, not waiting until it's launched in the US and then twiddling your thumbs before you actually look at any of the markets that have the high burden of disease here. So that's one part of the puzzle which I think only a few companies have been looking at. We've seen companies who are now ramping up their oncology business, like Merck and GSK, committing to voluntary licensing. So one day when their molecules are ready to enter the market, or before entering the market, they will reach Esteban and his team, and they will look at negotiations that could be possible in order to make sure more generic manufacturers are able to scale, especially in markets that are not a priority for these companies. Yeah. When I speak to the different companies and the CEOs, the thing that clicks, the moment when they realize that scale is possible, and as a company you need to look at the different models of scale, is the moment when they realize that their capacity to expand access is going to be limited to only a few countries. If a company like Roche is able to dedicate their time into Philippines, China, and get it right to ensure a sustainable access program in Philippines and China, then they need mechanisms like voluntary licensing to enter and expand access in other markets that may not be a core priority for them. And I think that's a very strong message that every company can understand. You cannot, as a single company, cover all the world's population treatment-eligible patients that are out there. I think there's been some new initiatives that are worth looking at, also bringing in radiotherapy, bringing in diagnostics in place. So Takeda is now working with the Cancer Alliance in Kenya, where they're trying to prevent a lot of these bilateral relationships and put them together into groups and strengthen that capacity for radiotherapy, access to treatment, education from the side. It's not pharmaceutical industry led, but it's facilitated. So I think that has been helpful.
So let's just pick up quickly, and because I want to get to our other two speakers as well, but just on those two aspects of potential solutions that Jayasree's just mentioned. One is obviously designing from the very beginning that level of access, so looking at clinical trials and so on and so forth, and making sure that they're in place. And the second is voluntary licensing. Indranil, to what extent is Novartis looking at those two questions?
So in terms of R&D, absolutely, that's one of the three pillars we look at when it comes to access to medicines. As we look at the unmet need, as we look at public health priorities and which areas to focus in terms of R&D, we take a look at what are the prevailing healthcare unmet needs across the globe and make sure that becomes part of the overall R&D strategy, but then also the broader commercialization strategy. So that's the R&D piece. When it comes to voluntary licensing, yes, there are many good examples of how that has taken place. Again, today, given the complications and the technology involved in bringing some of these medicines to society, the healthcare system infrastructure needs to be in place. I'll give a couple of examples. So one of our new breast cancer treatments, it's a CDK4 inhibitor. To give a CDK4 inhibitor, you need to have basic chemotherapy facilities in place. And in many of these countries that we operate in, basic chemotherapy facilities are not in place. I'll give another example, which is a bit non-oncology, sickle cell disease. This is the area that we are focused on significantly because this is a population that has not been paid attention to for many, many, many years. As we are trying to focus on sickle cell and what the unmet needs are, many of these countries do not have access to basic hydroxyurea. So we are working with these countries to make sure hydroxyurea is available. So I think our goal is to make sure the first step, whether it's basic chemotherapy, whether it's hydroxyurea, whether it's FLT3 testing when it comes to acute myeloid leukemia, that's in place, and then bring the more complicated molecules to society. Having said that, we recognize whether it's manufacturing or whether it's reach, our singular efforts will not be effective, so we want to join hands in public-private partnership, and that's where joining hands with a group like Medicine's Patent Pool will be useful going forward.
So I think I'm getting out of my depth here, but I mean, what you're saying, I think, is that these complex molecules and chemotherapy products require an ecosystem of capabilities around them that are difficult to create. Would you say that's a fair assessment? And is that something that is holding back this process?
I mean, absolutely. I mean, I think, but yes, but, I mean, let's put it this way. Back in 2000, people would have said, there's no way you can treat HIV in sub-Saharan Africa. Today, you have over 20 million people on HIV treatment in sub-Saharan Africa. Now, that does not mean that treating cancer is treating HIV. The level of complexity is much greater, but the level of complexity of HIV was much greater than whatever was being treated before in those contexts. So there is progression, there's significant challenges. And I think, but coming back to the hepatitis example, that's a good example where the diagnosis wasn't easy. There weren't hardly any hepatologists in low and middle income countries. So how you can even start thinking of hepatitis treatment?
Sure. Yeah.
But however, if you didn't even have a treatment, or if that treatment wasn't affordable, how are you even going to start thinking about what to do about it? So you need to be building, it's several building blocks, as he said, and I think that's where we need to start thinking of all the different bits and how they're going to fit together. Access to affordable medicines is one of them. If you only do that, nothing's going to happen. You need to be thinking about the other steps as well.
So let's look at some of the other dimensions of this problem. Let's go to radiotherapy and Lisa Stevens. We've heard today that there is a profound shortage of radiotherapy in many, particularly low and middle income countries, and that this is something that clearly needs to be addressed, and it could have a major impact on outcomes for cancer. Tell us a little bit about the work that you've been doing at IAEA to improve that process.
Sure, so thank you. I first have to mention that I've only been at IAEA 4 months.
Oh, right.
So I'm building on what many in this room have helped to create. So one of the things that we do to look at the entire system is we conduct impact reviews, and we do this in coordination with our other UN partners, WHO and Iyer, as well as UICC. So I do know that there are many experts in the room who have participated in impact reviews, so thank you. And there are also countries here who have benefited from that expert review report. So the idea is that in partnership with the member state, we look at the entire spectrum of cancer control. So I like the words that have been used yesterday and today: partnership, comprehensive, collaboration, because we really want to start at what are the registry systems, what's the burden of disease, all the way through screening, early detection, treatment, and palliation. Provide those expert recommendations back to the country so that they can follow on with the development of a national cancer control plan, which again takes into account all of these various aspects of the cancer control spectrum. And we also do have a program to help countries with bankable documents. So being able to raise funds for needed activities like radiotherapy, diagnostic imaging, that will enhance their ability to provide cancer services.
So how, now that you've done the surveys of countries, now that you've sort of looked at their national cancer control programs, are countries investing sufficiently in radiotherapy particularly? Because that's obviously, you look at the overall national cancer control program, but obviously IAEA is really concerned with radiotherapy.
Right, exactly. So that's what we look at specifically. And I again want to acknowledge some of the work that's been done by others in the room, taking into account the investment. So I've also heard throughout yesterday and today the investment in healthcare, the investment in UHC, but also there's an investment required in radiotherapy. And it's not just the machines, it's the overall integration of this service into the healthcare system. So yes, countries are quite interested in being able to provide this. Many countries now do not have radiotherapy capabilities. Some do have plans to send patients to other countries, to other facilities. But the bottom line, what we know is that about 90% of breast cancer diagnoses will be recommended for radiotherapy. Nearly 70% of cervical cancer diagnoses will be recommended for radiotherapy. And there is not that capacity in many low and middle income countries. So yes, they do desire to provide that to their citizens, but there's a needed investment and there will be a return on investment.
So in the spirit of sort of thinking about the solutions that we have been here, what do you think then, how do you think countries can align themselves around provision of greater levels of radiotherapy? Is there a linkage, as there is potentially in drugs and medicines, with public-private partnerships in and around this process? Is there a set of funding mechanisms that you might recommend? What is it that countries can do?
So absolutely, there is a pathway. It does require a long-term plan. So there's the human resources investment as well as the infrastructure investment and the procurement of equipment. We are working more and more at the agency with regional development banks. And what I really appreciate about the thinking of the banks is the thinking about infrastructure. So again, the Islamic Development Bank recently signed a partnership with IAEA to provide $10 million in grants to common member states. And the bank president is very committed to looking at endowment funds so that when you put a machine in place and that machine needs to be replaced in 10 years, the country does not move back to where they were 10 years before, but they actually have the ability to maintain the machines, maintain the human resources, and then replace the machine when it comes to the end of its life cycle. So there are processes in place to do that.
I suppose one of the challenges too is that there are plenty of machines sitting there not doing very much, partly because they haven't been maintained, or partly because there aren't the facilities or experiences to be able to maintain them, and machines that are also out of date, cobalt machines that are out of date. So updating those machines and creating greater impact more quickly with a larger number of patients clearly would have a significant, first of all, cost, but much better an economic impact, wouldn't they?
Right, so we have the opportunity within the PACT program to work not only with our regional partners in IAEA, but also the technical experts. You heard from May Abdel Wahab earlier today. Yeah. And so again, looking at what's appropriate for the burden of disease in a country, how do you maintain quality, how do you maintain the level of expertise in order to operate the machines?
Lisa, thank you. So Mary, let's move on. I mean, I realize we're running out of time as always, but let's move on to this question of healthcare provision and the patient in particular, because I know you've been particularly concerned with looking at this. And with healthcare providers at the forefront of affordability and quality care, and quality care has come up a number of times today. What elements of cancer care really need to be in place to adequately address the needs of the patients, do you think?
Well, cancer is very complicated, as many speakers have alluded to. We know how to manage this complexity, but you cannot just focus on one aspect of treatment. So I know that we have a number of new drugs. They're very effective. I agree that sometimes they actually are cost effective because they eliminate need for hospitalization and other procedures and lower the total cost. But in cancer, you need accurate diagnosis. We forget in this room, there are very few surgeons here, that actually 70% of all cancers who are cured with surgery. And the cure would not be achieved without surgery, and we don't talk about it. And part of the problem is there's no industry behind surgery. There's no sort of sector that actually cares about surgery. So it's a bit a forgotten element, and I'm a radiation oncologist, so I'm also aware that a few years ago, radiotherapy was also in the same situation, that people didn't realize that 50% of cancer patients would benefit from radiotherapy. And you need actually to make the case for investment in this modality.
So we forget, don't we, that countries like the UK, and I'm sorry I keep bringing the UK up, but it's probably the only one I perhaps have any knowledge of, have improvements in surgery have had massive impacts in the last 5 to 10 years on improvements in outcomes in cancer. Am I right in saying that?
Correct. And there's been a number of very valuable research documents, such as Lancet commissions on global access to surgery and global access to radiotherapy, that actually quantitated the potential benefit of investment in those treatment modalities. But I think when we look at individual modalities, we can calculate what would be return on investment, but we make a lot of assumptions. We make assumptions that are adequate diagnostics. We have assumptions that there's universal health coverage, patient can afford care. We make assumptions that there are drugs for cancer. We make assumption there's palliative care. So once we make all those assumptions, we can show that individual modalities have great impact on quality of care and return on that investment in terms of years' life saved. But that just means that when we implement cancer treatment, we actually need to integrate all the modalities. We cannot just focus on one. I sometimes talk about cancer care the way that, I think about cities. You think of New York, and you just decide that mayor of New York would say, I'm just going to focus on electricity. Never mind clean water, never mind garbage, never mind food. I'm going to focus. The city would fall apart, right? So cities are very complex mechanism and organism, and somehow it all works. I think we have to do the same in cancer. We cannot just focus on one thing. We need to integrate all the modalities based on what an individual patient with individual cancer needs. So it has to be focused on the patient's needs, but the response is what the modalities and what infrastructure, what procurement, what processes and systems exist to answer those needs.
So somebody once said, I think in a conference that I was at, that cancer is potentially a Trojan horse for healthcare system strengthening, and that there are so many things about cancer and cancer control, from radiotherapy to surgery to pathology, et cetera, that given a health system an opportunity to really deepen and become more sophisticated. Is that something you see as being?
I think it's Richard Sullivan who very frequently says that if you solve the problem of cancer, you would solve 80% of health system problems, because the cancer affects every system in the body, affects all the treatment modalities, and excluding trauma and obstetrics, cancer patients need all the subspecialties and all the disciplines in healthcare. So I think addressing the cancer problem will benefit health systems. There's no doubt about it. But we need to have more attention to quality and value for the money. And when you talk about value for money, you're talking about better outcomes for less cost. And we all talk about knowing how to measure the outcomes, but you have to be able to interpret the outcomes and knowing the context. So for example, we all think that the outcomes based on access to care, we know how to measure the extent of disease and cancer staging. UICC has been involved in that for years. Iyer in defining what exactly cancer, what's the biology of cancer. But there are many other factors that affect the outcomes and survival in cancer that we actually don't know how to measure that well. And
could you just sort of outline what those factors are?
So there's extent of disease and there's type of disease. When we have classification, we know how to measure that. Although, there's progress in genomics and there's increased science on that. But then there are patients, and the patient's characteristics we don't measure very well. And then there is what we call sort of environment and social determinants of health. And the social determinants of health may have quite powerful influence on outcomes, but we don't have a good schema globally to actually how to quantitate the effect of poverty, of lack of education, of stigma, of lack of housing, and lack of skill set, lack of quality of care on the outcomes based on population. And I think we need to understand those modifiers in order to be able to quantitate the value of the care that we produce. And I think that increasingly the National Cancer Institute in the US has a project now to say, how do you measure those other factors that affect the outcomes in cancer? How can we develop this system that's globally acceptable to do that? And for that, we need more research. And when I think about cancer treatment, we all focus on medical research. We focus on basic research on clinical trials to define better treatment. But when it comes to understanding the outcomes in a population basis, the implementation research, the social science research, I think we don't invest enough resources there. And, you know, we talk about cancer treatment and we talk about the need for integration of diagnostics, radiotherapy, surgery, and everything else. And we create cancer centers that are sort of like beacons of cancer care. But in many countries, those cancer centers are so busy with delivering of care that there's no mandate for research. The research is an afterthought. It's something, it's like icing on the cake. It's only afforded in high-income countries, while I would argue that unless we invest in research in low and middle-income countries, we will not be able to say whether what we know from high-income countries can be actually relevant to other parts of the world.
Mary, thank you. I realize we have really run over our time again, but thank you, everybody, for, I thought it was a fascinating session. Thank you very much for all your thoughts. Do please join me, and thank you, everybody.